Good morning, everyone. I'm Sibish. I'm going to present today about lower cross syndrome. These are my objectives: definition, clinical relevant anatomy, clinical presentation, common causes, examination, and physiotherapy aspects of management. Definition. So this is also known as pelvic cross syndrome or distal cross syndrome. Uh, Lower cross syndrome is the result of muscle strength imbalance in the lower segment. As you can see the picture, this crossing between. So tight if flexors and tight thoracolumbar extensors, and there is a weak abdominal muscles and the weak gluteus muscles. So this imbalance can occur when muscles are constantly shortened or lengthened in relation each other. The lower cross syndrome is characterized by specific patterns of muscle weakness and tightness. I have already discussed that cross between the dorsal and the ventral side of the body. So there is an overactivity and hence tightness of hip flexors and lumbar extensors. Along with there is underactivity and weakness of deep abdominal muscles on the ventral side and of gluteus maximus and medius on the dorsal side. These hamstring muscles are frequently found to be tight in this syndrome as well. So this imbalance result in an anterior tilt of the pelvis, increased flexion of the hips, and compensatory hyperlordosis in the lumbar spine. And what is the clinical relevant anatomy? So which muscles are affecting more? So lower cross syndrome involves weakness of the trunk muscle. That muscles are trus abdominis, obliquus internus, obliquus externus, and transverse abdominis, along with the weakness of the gluteus muscles. That is gluteus maximus, medius, and minimus. These muscles are inhibited and substituted by activation of other superficial muscles. There is also overactivity and tightness of the thoracolumbar extensors, that is retrospinae, multifidus, quadratus lumborum, and latissimus dorsi, and that of the hip flexors also, that is iliopsoas and tensor fasciae lata. The hamstring muscles compensate for anterior pelvic tilt or an inhibited gluteus maximus. And what is the clinical presentation? Here you can see the picture showing there is a slight hip flexion, slight knee flexion, anterior pelvic tilt, hyperlordosis, lumbar hyperlordosis, and thoracolumbar kyphosis also. So these muscle imbalance creates joint dysfunction. So this will cause ligamentous strain and increased pressure, particularly L4, L5, and L5 S1 segments, the SI joint and the hip joint. This will lead to joint pain, especially lower back pain, hip pain, and knee pain, and specific postural changes. That is already I discussed. Anterior tilt, pelvic tilt, increased lumbar lordosis, lateral lumbar shift, external rotation of the hip, and knee hyperextension. It can also lead to changes in posture in other parts of body, such as increased thoracic kyphosis and increased cervical lordosis. There are two common types, subtypes, type A and type B. Type A is the posterior pelvic cross syndrome. So in this subgroup, there is a domination of axial extensor because of the hip flexors are shortened. The pelvis is tilted anteriorly, and the hip and knee are in slight flexion. Associated with this is an anterior translation of the thorax because of an increased thoracolumbar extensor activity. So this picture is showing type A pelvic cross syndrome. So this gives an expression for the compensatory hyperlordosis of the lumbar spine and hyperkyphosis in the transition from thoracic to lumbar spine, which leads to decreased quality of breathing and postural control. Next is type B, also called anterior pelvic cross syndrome. So in this type, abdominal muscles are too weak, and too short. This is associated with the predominant tendency of axial flexor activity. Compensation is reflected by a minimal hyperlordosis of lumbar spine, hyperkyphosis of the thoracic spine, and protraction of the head. So this pelvis is posted more anteriorly, and the knees are in hyperextension. What are the common causes? Lower cross syndrome is often related to caused by poor posture or bad posture, caused by an increase in stress on these certain muscles. With the improper posture or form when exercising, or low awareness on how to poorly perform daily tasks, muscles can suffer from one-sided stress or high tension in certain areas. Other factors are such as sedentary lifestyle or work and leisure habits. In addition, exercise routines can play a role in possible lower cross syndrome pain through overused or overtrained muscles. Training certain areas of your body and neglecting other can contribute to the cross muscle imbalance that may be causing your condition. Also, this lower cross syndrome associated with large other conditions. These are included, but not limited to the lower back pain. Other conditions like lumbar sprain, strain, lumbar disc herniation, lumbar disc bulge, hamstring strain, hip flexor strain, quadriceps strain, rectus abdominis strain can be also associated with the lower cross syndrome. So, examination. So examination for lower cross syndrome should follow the same patterns for the examination of a patient for lower back pain. So we'll follow the almost all special test, postural looking, everything will follow the same. Position of the pelvis, there is usually an increase of anterior tilt of the pelvis. This can be associated with increased lumbar lordosis. Active examination like hip extension, hip abduction, trunk curl up test, all will do. Passive examination for the hip flexors, we'll do the modified Thomas test. This test can be influenced by the stretch of the joint capsule, and thus more specific tests should be performed to confirm the tightness of the adductors. Confirmation of tightness is clear when excessive soft tissue resistance and decreased range of motion are encountered on application of pressure. Tightness of hamstring can be tested with the straight leg test. Thigh adductors are tested with the supine lying position, lying in a supine line at the edge of the plinth. Tight hamstrings may contribute to the range limitation. If this situation occurs, bending the knee should increase the range of movement. Also, piriformis muscle test is with the patient in supine. If the muscles is tight, the end feel is hard and may be associated with the pain deep in the buttocks. Next is physical therapy management. But the solution for these common patterns to identify both shortened and weakened muscles and to set about normalizing the dysfunctional status. It might be include deactivating trigger points and removing muscular adhesions, perform myofascial release and trigger point massage to the particular muscles like gluteus, iliopsoas, tensor fasciae lata, application of electrotherapeutic agents on the gluteus, tensor fasciae lata, regaining the normal lumbar flexion mobility, core stabilization exercise to strengthen abdominal muscles, re-education of posture and body usage as well. So when treating with the LCS, the shortened muscles must be restored before performing on training on the weakened muscles. This is based on Sherrington law of reciprocal inhibition, which state that when one muscle is shortened or tightened, its opposite muscles relaxes. So commonly, some of the techniques, relaxation techniques, stretching and strengthening. So relaxation for pelvis, hip joint, lumbar spine, stretching for hip flexors, spinal extensors, lumbar muscles, strengthening for abdominal muscles, pelvis, gluteus muscles as well. Here I'm sharing some of the pictures, some of the exercise pictures, but this is not limited, but common exercise programs are showing relaxation for the pelvis using the physio ball, and relaxation for the hip joint, slow circles in the hip joint using the gravitational forces, and for the lumbar spine in cat-camel position, stretching of the hip flexors. Two variations are included. And second picture showing knee extensor stretch in prone lying position. Spinal extensors stretch in the sitting, and the second one is in the standing position. Different variations. And this is for the quadratus lumborum in standing. Hamstring stretch in supine, sitting, and standing position, as well as erector spinae. Gluteus maximus stretch, lying crossover a knee pull down stretch, first picture. The second picture, lying knee to chest stretch. Next is strengthening part. So we need to strengthen the gluteus as well as the abdominal muscles. So first picture is showing for the gluteus strengthening. That is a starting position and the finishing position. That is straight single leg knee to chest hip rise. Strengthening the abdominal muscles on the front side by using isometric hold in the plank position. So these are the deep stabilization system. In second picture is showing for abdominal muscles in the lower part. These are the different variations in supine and the pelvic bridging exercises. And second one for the gluteus muscles, prone, different variations. Sideline for the gluteus and using the TheraBand as well. So in conclusion, I think while assessing and treating the patient, especially for lower back and lower extremity conditions, always have a look for lower cross syndrome. We can identify the muscle imbalance and treat accordingly. These are my references. Thank you everyone.